right, thank you all for coming to the Discovery Slam today. I'm Dr. Kristen Wells in the Department of Psychology, and I study patient navigation, particularly in the area of cancer care. What, you might wonder, is patient navigation? Patient navigation is one model of facilitating healthcare that was coined by Dr. Harold Freeman, who's a surgeon from Harlem, who also was the president of the American Cancer Society at one point. Dr. Freeman noticed that when he had patients come to him as a surgeon, they came and they presented with very late-stage cancer. And he wondered what in the world he could do to help them. These were for screenable cancers such as breast cancer, for which many people shouldn't progress to that stage. And so he really became interested in cancer disparities, these differences between populations in cancer outcomes. And so he created this term called patient navigation, and it takes on other types of interventions and models that were out there before, such as community health worker model, care coordination, a lot of other things. And so he really kind of took this idea and put it out there and really advocated for it. And I was one of the co-investigators for the first study of patient navigation. We defined in this big nationwide study of patient navigation, it was this very nebulous term, and we made it a lot more defined, indicating that it's an intervention to reduce disparities for a defined episode of cancer care, for example, getting a screening mammogram. It focuses on reducing barriers, both patient level and health system ones, and it also focuses on reducing delays in accessing cancer care services. Delays in cancer are never a good thing. So what research indicates, and I've conducted some of this and other people have as well, is that patient navigation really helps people get cancer screening and early diagnosis services for cancer. So there's several systematic reviews that are out there that indicates that it helps with colorectal cancer screening, other types of screenable cancers. It's really good in the earlier stages, but it's not clear whether it's helpful. The research is mixed about whether it's helpful for cancer treatment, and oddly enough, that's where it's usually used. People are offered patient navigation assistance when they get diagnosed with cancer. It's also not associated with higher patient satisfaction. I got to write that article. They always give me the one where like there's no effect, at all. And then the training of navigators is also rather haphazard. Some of the variability in patient navigation, in whether it works or it doesn't work to help people get this care, is due to a few different things. One of the things is the fact that there are all these different types of models of patient navigation. You could be a patient navigator if you wished. If you're considering a career change, it's always out there for you. So patient navigators can be lay people who are familiar with the community, or they can be professionals, and these tend to be nurses or social workers. People who are really interested in the industry of patient navigation would say that you should have one of each, a team. But that's not realistic in the context of most healthcare. So navigators, we're not really sure when to apply which model where. And we're also not sure what they should know. So there have been 10 different articles, and when I mean articles, it's pretty loose. Some of them are in like magazines, that indicate what patient navigators should know how to do. And only a few of them are based on research, only about half. And so some of these agree with one another, but some of the competencies are very specific to a population or a particular service. So I recently did a study looking at what navigators actually do, different types of navigators across the United States. What types of services do they actually provide? And did that differ based on their backgrounds, training, skills, and experiences? Did it differ based on the different settings in which they were delivering health care? And did it differ depending on the patients and the characteristics of the patients that they saw? This was a nationwide study of navigators. So it was navigators. If you identified as a navigator, you were basically in the study. Most of our navigators, as you can see, were female. But we had a good span of different types of navigators. So you see we have a good breakdown of nurse navigators, lay navigators, social worker navigators, and this is the biggest study of navigators that's out there. There's not been a lot of national studies of them. So we collected data using online surveys, and we looked at navigator characteristics, whether they were bilingual, they had their different levels of education and training, whether they, in fact, were a cancer survivor. This is a career path for people who are caregivers and survivors. We also looked at patients, a number of different things about patients. But the one thing I'm going to present now is whether they had health insurance. And we also looked in the setting in which navigation was provided. In doing so, we also gave each navigator a 82-item Likert scale, assessing the extent to which, how frequently they provided a different types of navigator tasks. So, for example, one of these questions were, with how many patients do you provide information and help with applications for financial and drug assistance? So this was a cross-sectional study. All of these things were collected at the same time using an online survey. And what we did as we were analyzing the data, you can't do much with 82 items assessing patient navigation tasks, so we conducted a principal component analysis to break these into various sub-themes. And what we found is there are basically 5 different types of tasks, types of services that patient navigators provide. Almost everybody provides basic navigation, which is like assessing and following through with barriers. It's like in the definition of patient navigation. So everybody does it. Other things were making referrals and arrangements to services, coordinating medical visits and care, treatment support. This is mostly your cancer patient navigators. And then there's a group that provides kind of clinical trials and peer support. That's a very big thing in cancer care, trying to get people to understand clinical trials. And the peer support, for whatever reason, sort of went with that. So our analyses, we kind of compared these 5 services using t-tests and ANOVAs. And what we found was kind of interesting. I want to draw your attention to the black writing versus the brown. What you can see is when you look at the navigators who provided basic navigation was just about everybody, but it was mostly provided by patients with, or navigators with lower levels of education. For making arrangements and referrals, this is really solidly in the court of social workers. This is really what they trained to do, but it was also bilingual and multiracial navigators. Our allied health, which are like medical assistants and such, they provide care coordination, but then when you see the brown ones, you can see it's much higher level navigators, much higher educated nurses and social workers who provide both treatment support and clinical trials and peer support. When you look at the setting, it's also kind of striking what the navigators are doing in each type of setting. So you can see these top 3 are provided in hospitals, which is a lot of addressing barriers. Making arrangements and referrals are in community-based organizations, not necessarily healthcare organizations. And community health centers, that's where a lot of care coordination happens. But the 2 that are in brown are provided in suburban hospitals for the most part. Now one more. Take a look at this. This is the patients and their insurance status. Again, the top 3, basic navigation, making arrangements and referrals, and care coordination, were provided to patients who either lacked insurance or were on Medicaid or what's called Medi-Cal in California. On the other hand, treatment support and clinical trials and peer support were provided to those with private insurance. So what this tells me is that patient navigation is kind of going in different directions. Remember that first slide I showed you of Dr. Freeman and his vision for how patient navigation would reduce health disparities? There's an entire branch of patient navigation that is not focused on that at all. And yet we are all saying that we need to have one model or a specific model. We need to have core competencies, and that might not be the case. There might be core and specialty competencies that are needed. So I think we might need to actually redefine patient navigation, the field where it's going, to take into account that not all patient navigation is focused on the reduction of disparities. And we really need to come up with actual core competencies versus specialty competencies for the ones that are not necessarily providing disparities reduction types of interventions. That might be more specialized. I'm all done? All right. We still need more research. If you have any questions, let me know. All right. Thank you. That's the kind of research we need.
Yeah.
Questions? Thank you. I have a very quick question. So is this kind of a patient navigator, they are a professional career right now, or it will be in the future?
It's an occupation, yeah. So that's a question that I wasn't able to, or information I wasn't able to provide in my 10 minutes. I could give you like years of background information, but it's encoded, it's part of the Affordable Care Act. There's patient navigators who do certain things. There's accreditation standards that for hospitals and cancer care programs that include having patient navigators. It's an actual occupation. There's like professional societies for patient navigators. Yeah, it's like there's training programs. It's like an occupation, but an occupation that all of you could be. So we could be the science patient navigators, I guess. Yeah.
So what kinds of outcomes? Have you looked at outcomes as a result of having this type of service?
Yeah, absolutely. So the strongest outcomes, where it's been studied the most is early detection in screenable cancers. So breast, colorectal, cervical, a little bit in prostate. And what it does is it reduces people being lost to follow-up. That's what it does the best. So it goes after the people that have so many barriers that they wouldn't get follow-up care that was recommended. In this case, if you have a lump or an abnormality in your breast, for example, you're supposed to go through a series of steps to find out whether that's cancer or not. And some of it's really quick and other stuff is not so quick. Some people never get through that, and there's a good amount of it. A navigator is supposed to make sure that doesn't happen. So it works really well there. It also works with helping people get cancer screening for those same 4 cancers: breast, cervical, colorectal, and prostate to some extent. That's where it's the strongest.
So it's a little bit disconcerting that something that was supposed to be a tool to reduce disparities, if I understood you correctly, has become a reflection of disparities.
Correct.
If that's the case, what
I'm glad you got it.
Yeah, okay. All right, I paid attention. So if that's the case, what needs to happen?
It's been one of these interesting kind of phenomena. This is something that's been widely disseminated and implemented without the science behind it. And so it's like going after the horse that's like in Nevada. I mean, there still needs to be a lot of research, and we need to get more clear into what exactly we are trying to accomplish in the navigation field. So we've actually, the people who study it and the people who are part of professional organizations that implement it have started to get together to become more clear on what it is we're trying to do. And I think in some ways we have to allow for the professional navigators. There's not any really plan to stop them, because they actually meet the accreditation standards that were set up. When a hospital wants to be an accredited breast program or a College of Surgeons Cancer Center, having a professional patient navigator is what they want, and they almost always put it in treatment because they're not necessarily doing the work on the earlier stage of the cancer continuum. They're doing the work when somebody's been diagnosed. So they have to have one, and they stick them there. So it's, it's either rewriting accreditation guidelines to actually match the evidence. I don't know if that one's going to fly well with the navigation lobby, so to speak. But yeah, it's hard to say what to do. I've been grappling with this for years because it's just gone in these two different directions. Yeah.
Christy, I'd like to follow up on that.
Yeah.
It seems to me that part of your answer was these are two different pathways, so we need to recognize that and just strengthen the two pathways. But fundamentally, what that's going to mean is, especially in clinical trials, you will not have that diversity that you need to really think about the best optimums for society as a whole.
Yeah, it's really a strange way in which it's gone. I never predicted this, and it became like an industry. So there's an industry of kind of nurses in the nursing field, in the social work field, that have really, taken this on. It's good that they're out there, promoting clinical trials, but they're not necessarily in the places to get diverse patients to address so basic clinical scientists out there, this is a problem. All the people who are supposed to be driving individuals to help them make decisions about trials and to learn about trials are not reaching the people for which there are trials. And that's been one of the fundamental problems with getting people who are diverse in clinical trials. So it hasn't made it better, though it was supposed to.
San Diego's the place to solve that problem. Thank you very much.
Thank you.
I'll just say one more thing, and that is Christy came to us. She has a class that's ongoing,
Yes.
and her grad students helping, so she's going to run, but that seems like a pretty good excuse.
Yeah, I'm going to run to teach class, but that's my email. Thank you.